I'll invite the other Tony and Rachelle to come up, and then we will invite questions from the audience. So please come up with some.
John, there you go. Harriet Hiscock, I'm a paediatrician from Murdoch Children's Research Institute. When we've tried to reduce low-value care, particularly in the hospital setting, departments say we're not making as much money. So there's perverse incentives. This is using the Evolve work. What are we going to do about rewarding not doing low-value care, the perverse incentives, and how do we turn that around?
That's easy, someone said down the front. I have no idea. I've been trying to do this for 20 years, trying to reduce low-value imaging for 20 years, and it's actually getting worse, not better. And I know, particularly in the private sector, it's driven by money, and I know now they're trying to do more high-cost procedures, and they're putting low-cost procedures on the back burner. So I think that's where education will take you so far, and behavioural change, but we have to do it from the top down. We have to have regulation. We have to get rid of things that are low value or harmful, and the government can't listen to lobby groups that come and quickly reverse things. We've tried to take things off the MBS, and they haven't gone because of the powers that be. So I'm not a powerful person, but together in this room, we could be powerful.
And I think the role of performance-based care, which is one thing that the US does quite well in some aspects, we don't have, that I'm aware of in Australia.
Jennifer, do you want to add?
Oh, thank you. I struggle with this too, because I think that's what people say to me as well. Or if you're using medicines in a certain way, then we're not using the latest medicine that's got all this packaging and whatever. And I'm like, well, actually, there's no difference between the two. It's just that one's new and one's old, and the old one comes in a bigger sized package and we don't waste it. So I think it's, in a way, standing up and being able to have the support to be able to give the evidence back. But the other thing would be, and I was just thinking of this when you asked your question, is, do you just go to the CEO and the executive meeting? I would probably actually go to the board and say the board is going to be responsible for the financials, which are going to include these accounting standards, not just on climate, but also on nature. And this is what I'm getting from my management team when we actually try to lift our organisation up to what's going to be mandatory reporting for board directors. And the risk to the organisation is X, Y, Z, because I think that what happens is, particularly as physicians in the workplace, that we're dumbed down all the time by managers that are telling us what we can't do. And when you talk to people on the board, they say, oh, that's a real risk to our organisation. Why isn't that getting fed up to us? So up to the lathe through management, the CEO and to the board. So I actually think it's actually getting that time on the exposure to board members so they actually are aware of the risk that their management team is exposing their organisation to. And I know that that's been used in some organisations to actually bring it to the attention of the board, and board directors obviously have important director duties to ensure the sustainability of their organisation, which is different to what a manager's duties are. So that's my only thought. The other thought was to get colleagues together, so that maybe the people in this room or through DEA or through the college. We're doing some good stuff now, but please reach out on that.
Great, thanks. So, Tony, you also wanted to weigh in on this.
Yeah, just to pick up on Jennifer's point there about the importance of integrating this into the governance arrangements we already have in place in our health system. So Jennifer was referring to boards, which will, as she points out, have responsibilities in this area. They will be required of them very soon. So we're going to have to train those boards. But importantly, this needs to become part of the business of the accounting of healthcare. Accounting in healthcare can no longer just be about health outcomes and financial accounting. It's got to include environmental accounting, and it needs to be integrated. The last thing we need is another silo of work in a very busy system. It very much has to become part of our work and integrated into it.
Ingrid.
Yeah, thanks. Ingrid Schiff, Melbourne Uni. Great session, thank you. I just wanted to know, are we doing just the obvious things to these people ordering all these tests that are unnecessary or useless? Do they get a letter from the Department of Health saying you've ordered 200 shoulder ultrasounds and they're useless and we're watching you? Anything like that?
So, I'm not in the Department of Health, but I don't know, I mean, physicians in the room will remember that we used to get letters to say what we were doing, you know, the top 5 things that we were doing and what the top 5 things that other rheumatologists were doing. They stopped that and I don't know why. GPs do get quality improvement letters and the government's responsible for deciding the topic. So the low value imaging was their idea, and then we helped them to frame the letter to decide which low value imaging was low value imaging. But for example, that was really great, but they don't have any plans to repeat it. And we know that one-off audit and feedback, you know, we even showed that getting 2 letters was better than 1 letter, but that should be normal. They should just keep giving those letters. So now we've done a trial of pathology tests, and I won't tell you the results, leave that for Denise, but you know, that's a one-off, and so we have to keep talking to them going, but you're going to lose the momentum. You've got to keep doing the same thing. So we have to do much more. We can do audit and feedback in hospitals. We can feed back information to clinicians, and Denise, again, has done a lot of work in Victorian hospitals to feed back to clinicians what they're doing for things like low-value colonoscopy. I know in New South Wales they're looking at unnecessary hernias, unnecessary hysterectomies, and so it's all fragmented as well, and it's by state. But we all know in our area, like the Evolve thing, we all know in our areas what things we should stop doing. We just need help in getting it done, because no amount of clinician goodwill and will help us. We need the patients on our side. So, you know, one of the problems in care is, well, what do you expect me to do? Do you have something high value that I can replace it with? In general practice, they've got 2 minutes per consultation, so it's much easier to give them an imaging request than to describe why they don't need one. So it's a whole of system approach that we need to address the whole of system problems that we have, including environmental impact.
Okay, thank you. We haven't got much time left, so I'd just like to ask each of you very quickly, what would you like to see the Academy and its fellowship to do in the next year about the National Health and Climate Strategy? I'll start with Tony, then Rachelle, then Jennifer. You have to be very quick because we're running out of time.
Thanks, Fran. I know that you and I were part of a process with other fellows a few years back when Ingrid was leading this organisation, and I think that was a very useful process. Now that we do have the national strategy that Jennifer referred to, I think it'd be important to take a careful look at those 4 domains that Jennifer said, and to identify what, in practical terms, that can be done by the Academy, including, of course, scrutiny of the environmental footprint of health research, as I pointed out, using that international work.
I don't know where to start, but I'll just say, I know, but Tony and I have had a little chat, and our CREs on reducing carbon footprint, I think we've put it in 3 times. You know, we need research in how to reduce the carbon footprint of healthcare. We need many more people trained. We can't get experts in our university who know how to do life cycle assessment, so we need much more capacity building to be able to address the problem as well.
Okay, thanks. And last word, Jennifer.
Yeah, thank you. So I sit on CHEAG, and I think there are opportunities certainly to work with the society. I know that I've talked to the CEO of this group about that idea, and I think that your thoughts, Tony, particularly on research is a good one. I think that's what we all do in this society, and that's something that we could certainly help CHEAG with, particularly around the implementation. And because of its high level and well connected and well governed, I think that if we made a statement, that would have much more carriage than just like a local group of physicians, for example, making a statement. So I think probably linking it in with that. Unfortunately, we did have an interim CDC, and I'm not sure about the longevity of that and the Chief Medical Officer who was supporting a lot of this has retired. So it's in a bit of flux, but I think that's the only pathway that I can see that we could actually make very quickly quite a significant impact.
Okay, well, thank you, and thank you very much to the panel for a very thought-provoking discussion and on an absolutely crucial issue. Thank you.